Okay, let's start. Good evening, everyone. Welcome to the next session of Spice Root Classroom. This session is special again because we have the Northeast being represented today. Dr. Evelyn from Mizoram and Dr. Athiko from Nagaland. So they will be talking to us today on pain management in family medicine. So first I want to call Dr. Serin to welcome the gathering.
Good evening, all. A warm welcome to this wonderful evening. And today we will be going with our classroom from by Northeast chapter of Spice Root. I think this is going to be a landmark. So we all were trying our best to have such a session by the Northeast, and that landmark is happening today. And we all are so happy and we all are so proud about that. So let me continue with my welcome address. Today we have Dr. Nepuni Atiko and Dr. Evelyn as our speakers. Both are state leads from Northeast. Dr. Nepuni Atiko is from Nagaland and Dr. Evelyn is from Mizoram. Welcome, Dr. Atiko and Dr. Evelyn. And today we have Dr. Harshapriya as our moderator, who is a consultant family physician, and she's also a clinical fellow in pain and palliative care. She is the joint secretary of AFP Karnataka chapter. Welcome, Dr. Harshapriya.
Thank you, Dr. Sachin.
And we have Dr. Swati Bhatt as chief guest of today's classroom, who is a consultant in pain and palliative side care hospital, Bangalore. Welcome, Dr. Swati Bhatt. And we are expecting all our national leaders, state leaders to this classroom. Welcome, welcome, welcome all. And welcome all our Spice Root members, all our general practitioners, all students. Welcome, welcome all. Thank you.
Thank you, Dr. Serin. So I think we'll start the session. The first will be a case presentation by Dr. Evelyn. Over to you, Dr. Evelyn. Evelyn, we can't hear you.
You hear like that?
Yes, now we can hear you.
Okay, well, I'll just remove my earphone then.
Yes.
So good evening, everyone. This is, I think this is my first time or second time attending the classroom. I'm so sorry. My timing is always different from others. Anyway, good evening to everyone. And I'm excited to be here. I will be presenting a case about one patient from Mizoram. Before that, I just want to tell something about Mizoram. It's a very peculiar thing about Mizoram is that we used to do home visits very frequently while doing palliative care. As a family physician, also I used to visit sometimes. But this patient, why I want to share for tonight is that it's not a very nice thing to say, but a lot of people are doing tobacco, smoking and chewing tobacco, and there's a thing we call, you might have known that tuibur. Have you heard? I don't know. It's a liquid thing which they used to swallow. They don't swallow it, but they just keep it in their mouth for so long, and it's kind of a tobacco. So that is also one cause of cancer. That is the peculiar thing about the bad peculiar thing about Mizoram, that many of the people are practicing. So this particular lady also, she's doing that as well as smoking. So why I want to share tonight is that about this patient is that she, at the end of her life, when she's already crossed 70 years, she could not stop those two things, tobacco and that those two tobacco things, smoking and that tuibur thing. So what what I hope for our discussion is that how are we going to deal with that kind of patients who cannot, should we ask them to stop, should emotionally also she might having problem at the end of her life, should we ask her to stop all these things? So because of that, I choose this patient, besides her back pain, which we are going to manage. So if Dr. Atiko, can you please share the slide?
Yes. Now, okay, okay, the first one. Yes.
Yes, the first one.
Can you see?
No.
Case scenario. Yes.
It's visible to us.
Yes.
Simple. Yeah, I can see. So
Yeah.
the patient is 74 years old female from a semi-urban area. It's a little bit outskirt of Aizawl. Aizawl is the capital of Mizoram. So she's living with her son and his family of 4. Her husband already passed away few years back, and this patient was diagnosed with lung cancer, which has metastasized to her spinal cord, and she's having a lot of back pain, as well as shortness of breath. The patient already completed her chemotherapy cycles, and now she is brought home to be with her families. And actually, she doesn't want to go back to the hospital also, even if she has problem. That's why we visited her. So her past medical history is that she used to have, she has diabetes mellitus. She's on, her blood sugar is controlled well, and she doesn't have any hypertension or any other comorbidities. And the personal history is that the patient is a chronic smoker, like I said, and she started smoking since she was 18 years of age. And she used to smoke these local unfiltered cigarettes. It's not like it's not like this cigarettes we available in the market. It's the locally made one, which is unfiltered. 10 to 15 sticks per day. That's what she said, but I believe it's more than that, 20, maybe 20 to 25 actually. And she has also had history of cough at around 50 years of age. She started having cough, and she was treated with antibiotics for her pleural effusion. That time she was not diagnosed with cancer yet, and then she was improved. But when she was around 72 years old, she started having uh, hemoptysis and chest pain. So she was brought to the hospital again, and that was when she was diagnosed with cancer. So this is her main personal history. In her family, there is no history of family cancer or diabetes or anything else, but she was diagnosed with COPD, like I said before, and her husband died a few years back. She is living now with her family, her son and his wife, with 2 kids. One is 6 years old and another one is 4 years old. Still needs support. Who still needs support. And the husband is the sole earner. The son is the sole earner of the family. So the patient comes from a lower socioeconomic background, and they live in a kacha house with 2 rooms with no proper ventilation there, and they're still using this wood and coal as the main source for cooking. The patient also consumes, like what I said, mm, filtered water from the tube well, and her son is the sole earner of the family, like I said, and he is a carpenter in the area. So their income is not that much. And now her main complaint is that she is having trouble with breathing for the past 1 week with severe backache, and there is no relief with analgesics which they have got from the hospital. And she also has this blood in the sputum, and chest pain also is there. She cannot sleep properly, and she's losing her appetite also. Now the social issues are that they have financial problems. So for the family, it's difficult to go to the hospital every day, as also the patient also does not want to go. That is also the problem. And she feels that she's giving just trouble to the family. What she requests to us is that just let me live my own life, let me die in peace, let me smoke, let me do whatever, let me chew this tobacco, whatever I'm taking, and let me just die in peace. That's what she said. So these are the psychological issues. She has depression, she's helpless, and she feels that she feels that her smoking relieves her symptoms. And then she becomes very irritable recently, and she feels very helpless. So that's the psychological issues. And she also has the spiritual issues. Uh, she said, like, why to an old lady these things happen to me? Why do I need pills when I can just pray and die in peace? That's her concern right now. And the challenges we face, but I feel like we should discuss is about the pain. How are we going to deal with the shortness of breath and the smoking problem and the depression problem? So these are the things. So I think I can hand over it with Dr. Atiko for the pain management and everything, I guess.
Thank you, Dr. Evelyn. I think it was a very nicely presented case. So what I understand is our main challenges are we need to address the pain of the patient. Patient also complains of shortness of breath, and she's psychologically down, wherein she just wants to be left alone. So that is another concern. And her back pain is something which we have already mentioned. So I think Dr. Atiko is going to do a presentation, and probably certain questions are going to be answered in his presentation. So Dr. Atiko, can you go ahead with your presentation?
Okay. Okay, good evening, friend. Evelyn has highlighted some of the difficulty we come across, especially in the context of chronic pain. So I wanted to discuss with you about the pain management, how a family physician can play the role of pain management, especially in the context of complex and chronic pain. So back in 2010, International Association for Study of Pain declared that access to pain management is a fundamental human right. So with all these member countries and then the other community, to which India, our country, is also a part of it. So pain is one of the most frequent reasons for visit to family physician and other generalist provider. About 22% of all primary care patients have chronic pain, and family physician setting is ideal for addressing pain management right from the initial assessment to providing continuing care for chronic pain. So these are the common type of pain presentation to primary care provider, like backache, joint pain, chest pain, abdominal pain, or whatever, and others. Some are the complex pain problems as well. So in this discussion, I hope that we'll be able to come to know about the difference in pathology of acute and chronic pain, and also we'll have an idea of holistic approach to pain management. Also treat mild to moderate pain effectively at our level, and for complex and difficult pain, we can effectively coordinate with pain specialists and help the patient for continuity of care. So when it comes to pain definition, International Association for Study of Pain define that pain is unpleasant, subjective, sensory, emotional experience associated associated with actual or potential tissue damage or described in terms of such damage. Pain is not just a feeling in the nerve ending. Also, another definition said that pain is a somatopsychic phenomenon modulated by 3M. That is the meaning of pain, the mood of the patient, and the moral of the patient. One famous palliative care physician described that pain as what the patient said it hurt. The founder of modern palliative care, Dame Cecily Saunders, coined the word total pain, which consists of physical pain, psychological pain, and spiritual pain and social pain. So we'll be look into how to look into solving this problem and helping the patient in the following discussion. So a look at the pain physiology. The nerve fiber involved in pain transmission, those are A fibers. The A beta fibers are large one and they respond to light touch and light touch. The delta fibers are smaller and then they are sensitive to sharp sensation of pain. And C fibers, they are small and unmyelinated. They require high intensity stimuli to trigger pain response. So the sensory nerve from the end organ goes to the dorsal root of spinal nerve, dorsal root ganglion, and goes to ascend up to medulla, midbrain, and then end up in the forebrain in the sensory area. So here the green one is showing that this is inhibitory pathway of pain from higher function. So here this highlight that the cognitive and emotional process that involved with the hindbrain and then involved in inhibition of pain from the inhibitory pathway. So broadly, we can classify pain into acute versus chronic pain, nociceptive and neuropathic pain, also functional or organic pathological pain, or other words, opiate responsive, opiate resistant, or semi-resistant to opiate drugs. Here we need to know the basic difference between the acute and chronic pain pain presentation characteristic. So acute pain indicates tissue injury or potential or actual injury, and autonomic response is dominant, and it's limiting intensity reduced as the wound healing progresses. Acute pain is protective and it's one of the symptoms, whereas in chronic pain, it is multifactorial with neurochemical changes, and vegetative response is more prominent. It is unremittent and progressive, and it's a constant reminder of life-threatening illness to a patient. So it takes the characteristic of a disease. In acute pain, we know that they are mostly post-operative, post-trauma, or some acute abdomen or myocardial infarction. Most of them is acute pain are under moderate pain, and then 10% of them they are severe pain. So most of the pains are managed under the WHO pain ladder step 2 and 3. Most treatment are treated under concerned respective specialty and anesthesia, and we family physician also have a major role in it. So the difference I wanted to highlight that pathophysiology of chronic pain in which way it is different from acute pain. The pain receptor do not accept and do not adapt over time. Instead, there is a sensitization of nociceptor in dorsal horn and recruitment of silent nociceptor to adjacent spinal segment happen. And there is reduction in modulatory input from the brainstem. So as the time passes, the pain aggravated and worsened. So again, pain classification, it is broadly classified into nociceptive and neuropathic pain. Nociceptive is further divided into physiological and pathological. Physiological are like tension, headache, and cramp. And then if it is then colic and migraine pain. Under pathological pain, arthritis, trauma, infection, cancer, and then infection and chronic cancer pain. Neuropathic pains are further classified into nerve compression and injury. Under injury, it can be peripheral, central, and sympathetic mediated. So centrals are post-stroke pain or spinal cord compression pain. Sympathetically mediated pains are like dicosalgia or diabetic neuropathy, and then pain of nerve damage. So the basic approach to pain management are that we should have come to a proper pain diagnosis, then evaluate thoroughly, and then also explain what could be the cause of pain to the patient. It has proven that it improves compliance and concordance. And we have management, and followed by monitoring of what we are managing, how we are managing. So we have to pay attention to details of the patient, what they describe, not assuming, because pain perception varies from person to person. So I have taken this approach from CMDT. So ABCD of pain. So A is ask or assess about pain, which is the fifth vital as described. B, believe what the patient and family say it hurt. Then C, choose the pain control option. D, deliver treatment intervention. E, empower the patient and family by giving appropriate health education. Follow up the patient to reassess. So A, ask about pain regularly, which most of the time we may have assume and then presume and then may not ask the patient. So assess systematically if the patient say it hurt. So we know the common approach is the PQRST, or in John Mortach, it's given as Socrates, which many physicians prefer it. So we have to also ask about the goal of pain control and management preferences, and assess the cognitive response to it. B, believe what the patient said, because pain is subjective. We cannot measure with instrument, but we can listen to their cry and their groaning. You can also ask them to quantify their pain. We can feel the pulse and see the facial expression of people who are in pain, and allow the patient and family to be a part of the pain management. So choose pain control option, which is appropriate for the patient, the family, and the setting in which you are working. And choose the drug, the type, the dosage, route, and all contraindication and side effect. And consider not forgetting this non-pharmacological adjunctive measure play an important role in pain management. And now we have newer and newer technology developing, and then interventional pain management have been very appropriate and then cost effective in pain management. So D, deliver the treatment timely, logically, and in coordinated manner. E, empower the patient and family in the course of pain control. Follow up for persistence of pain, change in pattern of pain, and development of new pain. So some pain may be more multiple, not only one pain. So in pain diagnosis, we have to keep in mind about the concept of total pain, that which we have seen. The description of pain is to be looked into it, and then what could be the mechanism of pain, whether it could be pathological or functional, or the cause, the etiology, and also the psychological and social, spiritual, psychosocial, spiritual aspect of pain also. So that, keeping all this in view, in mind, we have to come to a proper pain diagnosis, not just pain. So in the assessment of pain, we use tool, because we can tool, even though we cannot measure with instrument. So these are common pain assessment tool in pediatric setup. So we'll be seeing this briefly. 7 years and above, we can use visual analog scale, and which is also similar to adult. So in this face, leg, activity, cry, and conceivability tool is used for infant and then children below 3 years. One Baker facial index, which we use it both for the children as well as adult. And then this this numerical scale, this can be used in adult as well as children. So after assessing the severity, there are various modalities that in which we can manage the approach the pain management. So I made an mnemonic of IMMAN, which is mean funny man. So I is interruption in the pain pathway, like interventional management, and modification of pathological process, like giving chemotherapy or radiation or like that, or psychological physiotherapy, and also modification of lifestyle, especially like the orthopedic or some pain which can be minimized by modification of lifestyle. And then analgesia is one main tool in which we can use. Non-drug, there are so many non-drug are there. So remember, I just wanted to highlight that in our situation, we want no pain, much gain. Whereas business people, they say no pain, no gain. But in our context, no pain, much gain. So I have taken this from American Association of Family Physicians, that care of a patient with pain consists of symptom relief, disease-specific treatment, patient education, occupational and physical therapy, also psychological approach, and appropriate refer to a pain specialist. So when it comes to principle of treatment, we have to be proactive and ask about pain, and use the least invasive route as possible, and use a holistic approach, because pain is not just a feeling on the nerve ending. So plan ahead of exacerbation and crisis, and ensure regular medicine and regular stock of supply, and review regularly. So in the management, we all are familiar with this WHO analgesic ladder. In this 3-step ladder, Adjuvant is used in all steps. And then in the step 1, non-opiate drugs are plus minus Adjuvant. After reaching the optimal dose of this non-opiate drug, we can move on to second step, which we use mild opiate to intermediate opiate like codeine and then tramadol. And then if with this optimal management, if it is pain is still persisting or increased, we can go to strong opiate on the third level. So when using this, applying this WHO analgesic ladder, we are to look into this rule that by mouth, by clock means as far as possible by mouth, and then follow timely, not just PRN, by the stepwise, and then also individualize, and then timely assessment and coordinated manner. 90% of the pain can be effective control with using WHO pain. This is just one of the one of our patients who extremely adopted this posture to relieve her pain, and then after treatment, she is relieved, and then she started playing with her husband. So the expected outcome is that chip away manner that which in the pain relief by night in 12 hours, and then the 48 hours daytime rest, and then relief during movement after 72 hours. So most of the patients, they are happy if the level comes to 4 and to 6. Pain greater than level of 2 is unacceptable, so we should look into them. So these are the we all know that the common drug which we need to look up and then give the optimal dose timely. So non-opiate drug and then opiate drug commonly used in available in our country: morphine, fentanyl, codeine, and then tramadol. So this is about regular medication and irregular medication. So PRN is not recommended that we give regularly, so that we can maintain a constant plasma concentration of medicine in our blood, so that the pain is controlled in a very proper way. So other drug which we commonly use, adjuvant drug, they are corticosteroid, antidepressant, anti-epileptic drug, muscle relaxant, antispasmodic antibiotic, and then night sedative as well. So this is the pathway that which adjuvant drug they act. So other non-pharmacological approach are that music therapy, acupuncture, and then reflexotherapy and touch therapy. So we have to address the pain in a total way, considering all this keeping in mind. So in the spiritual pain, we this part of our country, we have like some myths that like the sin of the forefather is causing the pain, and then sickness comes from God and punishment from God. Those are the things that which we need to correct and help them. And then social support, as said, like family, physician, home support, networking with NGO. So in conclusion, this realistic assurance is a form of preventive pain to the pain medicine. And peace of mind is a powerful adjuvant to pain relief. Patient and family, they are at the core of pain management planning team. And then holistic approach and continuity of care to the patient is important. When curative means fate, care needs increase proportionately. So thank you so much.
Thank you very much, Dr. Atiko. So I request the participants to post any questions if they have in the chat box. We could take it as it comes. And to take this forward, I would like to ask Dr. Evelyn, how did she manage this particular case which she had presented? How did she go around this case when the patient has finished her chemotherapy, she's come back home, but she's still in pain, she has breathlessness? and she's very psychologically down, not feeling all that great about the things happening with her. Dr. Evelyn?
Evelyn, unmute your mic.
Evelyn, you're
Sorry,
on mute.
sorry.
Yeah.
Sorry. With this particular patient, what we did was that it was a team effort. So we brought a social worker who used to, who can talk with the patient about the emotional issues and all those psychological problems. So he dealt with the patient, talk with the patient, but about the patient, about the main problem, the psychological problems. But about the pain problem, she was given this Ultraset, tramadol and paracetamol combination twice a day. So we are thinking of giving her morphine, which the patient's party, the son, refused because he thinks that he has known about the morphine. He thinks that that will sedate her and it will cause her to sleep forever or something like that. So we were having some problem with that. So the only thing we can give the only medicine we can give was like what Dr. Atiko was saying, that the non-opioid drugs along with the opioid, that low opioid drugs. So that was the only thing we did for her pain and the psychological, the emotional problems. And we gave her a drip and everything because she could not eat, IV infusions. And that was all, I think.
Was the pain controlled with Ultraset, and what was her pain score when you went and saw her?
It was quite high. She could not, the time when we reached, she was in severe pain. But after we went there, after giving one tablet, she was a bit reduced. But then after few hours, by the time we went back home, the son called us again, and then he said it's raining so much and all. She's screaming like anything, and since we don't have time anymore to go there, we just asked him to give the tablet again. So that was the main problem actually.
And how about her?
Far away, so.
Do you have anything to add, Dr. Atiko?
Yeah.
Any suggestions?
Yes. From my side, I would say that like if we could get the contact number of this patient, and then after following giving the medicine, that she should be follow up and then call about the pain management control, as Evelyn have said. Here in this situation, I think she has been given, but the follow up might have been a bit shortcoming and then erratic. So, and then as you say, like tramadol was given 8 early or 6 3 times a day or like that. So I think according to this, yes, if we apply this WHO pain ladder, we have to give it 6 early, and then if it is not relieving enough, then we have to increase the dose to optimal dose, which in tramadol we can make it up to 400 milligram in 24 hours, and then the add-on drug also we can use.
Okay, as a follow-up to this, maybe what I would like to add is probably one is the challenge of busting the myth of morphine, and second is probably to identify what kind of pain she has, and are we addressing that kind of a pain? Is it because usually it is seen that people with cancer have multiple pains.
Yes,
right?
true.
So
yes,
I think Dr. Swati can add a little bit more on this. Dr. Swati, are you there?
Yeah, thanks, Harsha. First of all, thank you, Evelyn and Ethiko, for a great presentation. That was a great effort on your side. Thanks a lot for that. So moving on to the challenges which you faced while treating this patient. As you said, the first challenge you had was convincing the son for the morphine. Having said that, as Ethiko said, we could add or we could escalate
using tramadol. Considering the age of the patient, I would not suggest that kind of a dose as high as 400. It will bring more of the side effects at that dose. So the minute you start escalating or going up anywhere above 100 or 150 with tramadol, it will bring more side effects than causing any at all pain relief. At the end of the day, it's a weak opioid. A patient, as you said, is CA lung with spinal mets. I don't think that a weaker opioid would really suffice. Now, cancer patients, you have to understand, as Harsha also mentioned, that the pain is multifactorial. So it could be either because of the tumor compressing upon whatever, it may be the nerves, or it may be a spinal vertebral met, which is an expanding one. So the pressure of that, it could be anywhere else in the body, which is an expanding capsule, which gives rise to pain. There could be ascites, there could be pleural fibrosis, or there could be a pleural effusion. So there are multiple reasons to the pain. So the first and the foremost thing that I found you could go a little step ahead was to, first of all, categorize her numerical rating score. That's a very important tool for you. Once you have a numerical rating, say like whatever, if you say it's like extremely bad, the pain is high, so maybe it was something like 8 or 9 on 10. So once you do the scoring, the next step would be, pragmatic approach would be to find out whether there's a neuropathic component involved in it. Is the breathless also super adding to the pain? As I can see in the presentation that there was a pleuritic chest pain involvement there. So all of that, you have to see a whole lot of other factors or the kind of pain it is. Usually cancer patients have a mixed pain, which is a nociceptive and along with neuropathic component to that. So if you have anything of that, once you delve into finding out what it is it radiating, is there any radiation along the dermatomes or along the upper limb, lower limb, or wherever it is, you could kind of add co-analgesics over here. One would be very important to convince the family. As a pain physician or as a family physician, a palliative care physician, it's very important that you spend more time with the family, and at the end of the day, you have to convince, you have to burst the myth of opioids. So this kind of a thing has to come from you, and you have to convince the relatives or whoever is the decision making, the key decision maker of the family. So that's very important. I think the other aspects of this could be, if you have a referral center, a higher referral center, it would be good once you are dealing with pain patients or cancer pain patients to have an association with somebody who's trained into a little advanced procedures or intervention procedures, who can do a little bit of the interventions to alleviate the pain without having the side effects of the opioids. So that can come a big way. In fact, the WHO ladder was created for the nurses. Now, there's a lot of, in the pain world, all over the world, a lot of consensus and a lot of debates have been going on that the intervention, which was earlier thought to be the 4th or the 5th step, should be the one to actually keep it in the first stage. The idea is, if you can get away with an intervention, a locally effective treatment, you can get away with a lot of side effects of opioid or tolerance or cross tolerance or even addiction. Nevertheless, you should very categorically, very strongly tell these patients that the chances of cancer patients having an addiction is very minimal. Because these patients come to you in a terminal stage, so most of them would not really live that long. If you have a longer period, then I think you can choose from other interventions or other modalities. So it has to be a sum total of all of it put together. So I would suggest, you could go with a higher opioid and use of co-analgesics. Like you have a wonderful co-analgesics, you have the NMDA receptor drugs. You have clonidine, you have dexmedetomidine, all of this act centrally. You have SNRIs, which is the serotonin norepinephrine reuptake inhibitors. So all of those could be added over here. So that you can add other anticonvulsants as well. So you have to look at a lot of options which are available.
Thank you, Dr. Swati. I think Dr. Mohan has posted a question which says, what is the current ruling on procuring use of morphine and other narcotic analgesics at primary care setting, especially opioids? I think Evelyn could probably take this because I think their hospital has procured recently, I mean, not recently, but yeah, they have procured, they could get morphine, which was initially not available. Right, Evelyn?
Yes, yes.
Yeah.
After we have been trained in palliative care, that foundation course and the certificate course, after that, the hospital could apply for the license to the pharmacy, the Directorate of Pharmacy. So because of that, we can indent the opioids, especially the morphine, which was not available initially, the tablets. Injectables were always available, but the tablets were not available before. But the thing is, right now in my hospital, we could just do that, but we could not. We have not practiced giving out to the patients because I don't have any other proper staff to do with it, like to maintain the files, to all those things. They have not been given me that, so we could not do that. But in other hospitals, that is the way it is done. After getting the certificate of palliative care, then only we can procure that opioids. And also one thing I want to add here is that some of the medicine doctors, the medicine doctors, surgeons, anesthetists, what our director of pharmacy told us was that this also they think that they can use the morphine tablets, but in fact only those who are trained specifically for using morphine should be able to prescribe the morphine. So what happened was that uh, these hospitals also, in our hospital also, those people, I don't want to say people, those doctors also, they used to try to give morphine tablets, but they were not allowed because uh, they need that certificate in their name. So I think if you want your hospital to have the opioid, or if you want to have an excess of that morphine tablets, you will have to apply for that after getting the certificate. So that's how it works out here. I don't know in other states how it works. It's a bit complicated here in our state.
Harsha,
Even if
that
you are,
question, yeah, that question just came up.
if you are a physician or a PG or whatever, if you are not particularly trained in that opioid, or if you don't have that certificate, you cannot prescribe it. That's what they told us.
Yeah, I think this question can go to Dr. Swati. So, Dr. Swati, we have been hearing that the ruling is now a bit relaxed on use of opioids by the primary care physicians. I'm not aware of this. I've heard somewhere. So, is there any amendment to the rule where that previously it was mandated that the primary care physician should be certified and trained in palliative care to use these opioids?
Yeah, it's true. Still, there is ambiguity about the ruling being made on whether who uses the opioids. You need some form of training on opioids. Now, it's a question of like the anesthetists most often they are trained, or the cancer oncologists by themselves. They have a fair good training of an understanding of the use of opioids. Now, primary care doctor, if it would be actually pragmatic to have some knowledge or some training on opioids. Now, at the end of the day, in a country like India, where we practice in tier 1 countries, or somebody is practicing in a tier 3 city or in the village, if there is an issue with opioid, which is like over medication, sedation, or there is a critical event that happens, death can happen because of an overdose or sedation, in that event, it might be difficult for you. And if the family chooses to take an action against you, then it will be difficult for you to defend. So I would suggest to practice safe and have some form of certification, definitely that you are well versed with the use of opioid.
Thank you.
Okay. Any other questions? Or so we discussed about this managing the pain from the medical point of view, but how do you think we can deal with the addiction? It was another question which I think Dr. Evelyn was also kind of looking for, because there is a lot of addiction. This lady at the age of 72, and it's very difficult to give up on those kind of addictions at that age. So how do you think we could deal with that? Dr. Atiko, you would like to take it?
Yes, dealing with or abuse use of opiate as such from the medical this in the palliative care context has not yet happened so much. That is what they have report. That is why I think they have made some amendment rule, and then it has been processed that the doctor should have easy accessible to opiate, so that the pain management can be controlled in a very well. So, but I think the morphine rule, opiate rule, is the central has made for it. But I think based on the state also, maybe the issue of this in aramide, we call it registered in medical institution. Here in this part of Nagaland is also one of the drug problem state. So that is why here with this here in Nagaland, so far the issue of this morphine, they have approved some of the institution, but they are also very strict with the regulation. Also, like if we are not able to maintain the log, register, and safety of the storage, and then anytime they can cancel the license, and then we may end up with a problem also. That is what we are very careful, and then with documentation is very important. So the addiction problem due to opiate prescription has not yet come up. So far, we have not dealt with come with that issue like that. But to prevent such kind of abuse of morphine or opiate, we encourage every patient who have taken the purchased the medicine to return when they didn't need it longer, like the patient expired or they doesn't want to take anymore. In that situation, they have to refund it. And then most of our patients, we have got contact of all the patients. That is why we are able to trace back and then able to retrieve all whatever is not needed. So as said, that morphine tablet, it's not transferable. So that is why we encourage that. And then that is how we are trying to deal in with the misuse and then proper use of. So the physician, when we are given the liberty to give opiate, you have to justify it and ensure that it is not abuse. In that way, we are trying to manage it and then able to do it, deal it with well so far. That's all from my side.
Yeah, the opioid addiction is very difficult in cancer patients, as Dr. Swati already mentioned, that the kind of dosage what is required for opioid addiction is really very high, and these patients come to us in quite a later stage. So it is less likely that cancer patients get addicted. So I was
Can I comment that, Harsha? I think what your question was, I think you meant about the smoking of the patient as addiction, right?
Yeah, that is the second part of the question. Yeah.
So can I come into that?
Yes, yes.
Yeah.
Please.
So I think it's absolutely challenging, and a patient who has been on with an addiction like smoking is, as it is very difficult to de-addict in a normal, healthy individual or with some comorbids. Now, in a cancer patient who's terminally ill and has many other issues like the psychological issues, the fear of death, the given up state, hopelessness, I think challenging that addiction would be very, very difficult. Not only difficult, it's not pragmatic really to kind of, look at that aspect of it. So nevertheless, there are nicotine patches which are available. So if a family like this one was not a very socioeconomically, well-to-do family, I would say, if there's another family which you feel that it's slightly better, and the patient is in a state that he can understand or she can understand what you're trying to push through. So you can, to such a patient, you can explain what are the drawbacks of having the smoking, say for example, or alcohol or whatever. So all those habits are going to just add upon the treatment, add against the treatment that they are getting for the cancer. So I think if it comes from the patient, the understanding and the willingness of it, you could try all those possibilities. I think the other issue which I wanted to actually bring in over here was as a primary care physician or as a family medicine expert dealing with a huge lot of population who comes to a primary care physician or family medicine. It's very important to realize at the earliest the importance of ruling out the red flag signs. So your red flag signs are any infection, any fracture, if it's a tumor. So if it's a patient who's coming to you in an elderly age group or a very young age group and having pain, if it's a ongoing motor progressive loss or sensory progressive loss, if there's any involvement of bowel bladder symptoms, I think you should be totally vigilant for picking out these causes, because nowadays the incidence of cancer has increased as much as we are aware that it is there. So we should be very, very categoric and picking up such patients so that we can give them referrals to the nearest oncology centers early in time.
Yeah, thank you, Dr. Swati. That was a very valid point. And as we see that, it's very, Dr. Mohan has mentioned a very good point. He says that we really need to see a collaborative approach between the palliative care between the family physicians and the hospital-based pain specialists. So as family physicians, it is we definitely play a very important role in palliative care in the approach the palliative approach which we take in treating a patient or seeing a patient, not seeing patient just as a patient, but the entire being of the person, and giving a very holistic approach. But in the entire thing, it is also very important that we also know what are the other things we can do to help the patient at the earliest. So and pain is such a common symptom which we face, which we get. The number of patients we see with different kinds of pain is much more than any other specialist would see. So as family medicine people, we need to identify different types of pain. We need to see what are the different modalities which are present to address these pains. And it is not only about the cancer pain, but it is pain in general. So, if Dr. Swati could just highlight on certain aspects wherein how we could pick up pains which needs a referral. You have already mentioned about the red flags, but over and beyond that, how could we deal, and what are the latest things which are happening in this area, so that we are aware that such things exist and we could probably use it when we think there is a need, and we could help the patient lead a better quality of life.
Yeah, thanks, Harsha, for that question. That's a very well put up question. See, as I mentioned already, so at the earliest site of a patient who comes to you with pain, if the patient responds to your treatment or any analgesic over the time that you have prescribed it over, so things look like, and your basic investigations look like okay. I think it's an adequate treatment. But if you feel that there is an ongoing pain, please do not keep prescribing painkillers and medications. You need to evaluate the patient. You need to look into all the possibilities which could be present. So please never hesitate to go for investigations, basic investigations like CT, X-ray, and MRIs. Definitely add a lot of value to picking up these things early in time. In my clinical practice, we see the whole lot of cancer patients who come. So usually when you look into the deeper history of the patient would have been going from one doctor to the other with some ailment, whether it is a gastric ailment or whether it is leg pains or it is a back pain, which has been over and on for years being treated by analgesics, and it's just been like on and on going on. So I think you should never ignore these signs at the earliest. So look for any loss of weight in these patients, unexplained loss of appetite, any pain which is not settling around with the analgesics. So it should ring a bell that something is going on wrong. So any sensory motor changes, it should clench you to think that there is something going on which needs further investigation. So investigate all of these at the earliest. Once you have come to a diagnosis or you have a report which suggests you something further needs to be done about it. So nowadays, we've made advancements in technology in every field. So is the evolving field of pain, for that matter. So, at a point of time in the 80s, we would have never thought that we could get away with the CABGs, the cardiac surgeries. But nowadays, who would have thought at that point of time? But nowadays, we get away with so many MIs, and they are treatable just by, the placement of stents, etc. So stroke at one point of time was a morbidity and had fatal results. But nowadays, the interventional radiology has done miracles in that as well. So similarly in pain management as well, we can treat mostly all the conditions, and we have techniques like vertebroplasty, Spurkinin. All of these are done locally without administering any anesthesia as a daycare procedure. And they actually, you can ward off against all the side effects that are come with a whole lot of otherwise, using NSAIDs, which cause nephrotoxicity or liver toxicity, etc. So you can get away with all of those, and the side effects like constipation, nausea, of using opioids and all. So you can do a lot of those kind of things, not only in cancer pain, but also in non-malignant pains. We can use those interventions. Nevertheless, the importance of alternative medicine or alternative approaches like massage, TENS, ultrasound diathermy, these all have their own role, or even cognitive therapy that also has its own benefits. Imagery can really, mirror imagery, that really is a great rehabilitative technique that really puts patients who are really suffering from pains like CRPS or any other neuralgic pains, phantom limb pains. It can be really very beneficial to such kind of patients, or even for central pains, which are like stroke pains, post-stroke pains, etc. So we can use a lot of techniques. We have spinal cord stimulators, we have peripheral nerve stimulators. We can do a lot of those things there, and along with, as I mentioned, cognitive behavioral therapy. And there's also a component of emotional aspect. So pain is never a secluded entity from emotion. Whenever any patient is there in a chronic state of pain, he will definitely have the lot of other burdens of emotional burdens. So depression, anxiety, sleeplessness, inability to move around, social insecurity, economical insecurity. So you have to see a patient in total. You have to address all of these issues. So it's a good idea to involve a good psycho-oncologist in your team who can carry on all of these assessments, if not you yourself, but they can carry on all of these assessments and give a good therapy to these patients. So looking at a patient in pain is, you have to bring in the concept of total pain, as already mentioned in our previous slides. So I think that is the way we need to approach the patient.
Thank you, Dr. Swati. Thanks a lot. And I think with this, maybe we can just wind up the session. I have few points take away as a family practitioner, as well as being in pain and palliative. There are few things which we should never undermine. One is that pain is definitely a part of palliative care, no doubts about it. But we are all doctors. So, as a doctor, we are the team leaders, and our team in palliative care comprises of social worker, nurse, psychologist, dietitian. We all work as a team. So, once we identify the needs of the patient, irrespective of their socio-economic background, each one takes up their role as per the delegation, and we doctors, we identify the medical needs and we intervene appropriately wherever required. Having said this, there are few things which we should never take it for granted. One is our wonder drug, which is paracetamol. We use it left, right, and center, and believe me, that is one of the best medication. And we have seen so many prescriptions which comes without paracetamol, and when we add paracetamol, patient gets a lot of relief. So just because we don't have morphine, we don't have strong opioids, doesn't mean that we can allow the patient to suffer in pain. Pain is something which we should know hesitate where it is required. Use multiple medicines, like there could be we may have to use adjuvants like antipsychotics, and for neural pains, NSAIDs. And one of the NSAIDs which we should definitely use it, but the
Harsha, 1 second.
We lost
couldn't, yeah,
that
the
we could
exact,
probably prefer
the
to
keyword,
of it.
the most important drug, we lost the name. Kaun sa tha?
Sorry.
We couldn't hear you exactly at that point when you mentioned which is the definite drug to be used. She's having some connection problems.
Again,
I think
lost
Dr. Swati, you can tell, I'm
Okay.
sure.
The drug which we should avoid.
Avoid nahi,
No.
definitely use, you said, na? The
We couldn't
Connectivity
understand
issue here.
actually whether she said use or not use.
No, we should not use
should
diclofenac.
not.
We
Okay.
should not use, we should avoid.
Harsha, we cannot
Known
hear
and stop
you.
using it, and instead we could use brufen, which is a little preferred than diclofenac. And then if we have other weaker opioids, we have tramadol, which we can use. So not having an opioid, not having a morphine doesn't give us any permission to allow the patient to suffer in pain. There are different approaches, as I've
About
already
the
mentioned.
COX-2. I think you
COX-2
mentioned
inhibitors.
about the COX-2 inhibitors. They have
Yeah,
a real good role.
they have, yes, they're very good role. Yeah.
I would not say that diclofenac or any of these NSAIDs cannot be used. It depends upon the stage at which the patient is. Of course, if you have a patient who has an allergic or an asthmatic patient, there's a total absolute no to diclofenac use. It will precipitate an anaphylactic reaction. But where you have a patient who is like terminally ill and you do not expect a long course more than a few weeks, I don't think so. You should hold back yourself from using diclofenac when it comes to availability of other drugs not being there. So you can go ahead in a terminally ill patient. Definitely, you can go ahead. If best would be to use COX-2 inhibitor like Inhibitory, Coxib, and all of those. That would be a great idea to use all of them.
Yeah, and the last the thing is, after adding all these things, the psychological, the spiritual, and the social aspects also play a very important role. Nevertheless, it is all very important. Along with medicines, we need to address all these things, and which has already been mentioned, as it has to be approached as a total pain, a total approach, and not as an individual. Each and every, you can't just give the medicines and to think that you've done your job. So I think with this we can just wind up, unless we have another question. Any more questions to take, Jyotika?
Not from mine. Mohan sir, would you like to add anything? Evelyn, anything?
Yeah.
Yes,
Evelyn,
yes.
you have something?
Yeah.
Yes, yes. I just want to ask about ma'am, Swati ma'am, about the smoking issue, which I was referring in the previous slide, about this kind of patient who is already 70 plus years old. She could not stop smoking. There was a discussion among our colleagues whether we should continue to allow her to smoke or not to smoke at all anymore, because that was the main issue we had while we were dealing with her breathlessness and her pain and everything at the end of life care. That is what I just want to know her opinion with.
See, to be honest enough, I told you, like, we have such patients in my clinical practice. We do see such kind of patients. Now, the younger ones around and the literate ones around who can find reason in what you are saying, kind of can try. And if they by themselves are willing to de-addict themselves, you could go with, as I mentioned, the narcotic, the nicotine patches, etc. You get chewables, you get patches. So all those can be tried by those patients. But again, smoking as a de-addiction is quite difficult. We do use methadone sometimes to de-addict patients. Now, again, methadone requires a lot of training. So whenever you are dealing with methadone, etc., you definitely need to have a lot of training, all that. That is, one of the approaches that you can. But
probably Dr. Swati, probably what she's asking is like, you are dealing with a patient who is nearing an end of life
Yes,
care,
yes.
and at that situation, if
at that point, that's what I
No.
said. At that point, it is very, very unrealistic to ask.
Stop her.
You can always, as a doctor, advise them, but don't hope that they will actually follow that. It doesn't happen.
Yeah. And one more thing is,
You can
this
only
is
give symptomatic relief to such patients. You can ease
and
off whatever best is possible.
and off the label, this is an off the label thing. That is, these are the patients who are in their end of life. So when we're talking about total approach, if that small little thing is giving them satisfaction and they're happy with it, I think we should just let it be
Not
and
to
just.
wait all.
I
Yes.
think we can just let that
Yeah,
be. As doctors,
probably.
we can advise, but we don't. I don't think we need to really insist. Yeah.
Yes.
This is off the label, please.
Yes, yes, of course. I mean, we don't say yes. Probably we cannot say no. It's like that. We leave it at
Yeah,
that.
exactly.
Yeah.
Exactly.
Yes.
Exactly. Yeah.
Okay. So I think let's wind up. And thanks a lot, Dr. Swati.
Point of, I think Archana wanted to bring
As a
a
point of question here.
Yeah. So as I mentioned, that it requires experience and it requires training. That's all. So if one has, definitely you can go ahead. But then again, in elderly patients, you need to be very vigilant with getting the ECGs. You need to tap a lot of those issues before you start off dealing all of that. Since you already, since you already have an expertise into that. So I already mentioned, anybody who's trained into it, you can go ahead and absolutely do that.
Thank you, Dr. Swati.
Yes, I think that clarifies.
Yes. So,
Yes.
any more questions, or we can call it a day?
I just want to add one comment here.
Yeah, Dr.
If
Mohan.
time permits.
Yes. Yes.
Yeah. So there is a lot of misconception, I would say, among the public as well as among the medical fraternity, that pain and palliative care means only end of the life care or cancer care. I think we have to understand that
Yes.
we are practicing pain and palliative care in our routine practice. It is required in our day-to-day practice also. So it's my request that we should never associate pain and palliative care only with cancer care and end of life care.
Absolutely.
So we require this even for treating diabetic neuropathies, post-op pains. So we have been practicing pain and
the ever famous low back pain, low backache.
Low back pain. And we do use, of course, we may not use opioids that much, but we use anticonvulsants, antidepressants.
Yes, antidepressants.
Absolutely.
Primary conditions.
Yes, yes.
Yes, very rightly said, Dr. Mohan. Pain and palliative is not only to cancer, it is the general
daily
approach on a day-to-day basis. And I think as family medicine people, we are just doing that, and we need to continue doing that. It's definitely not only to cancer related and not end of life care at all. Yes, very rightly said.
Okay.
Thank you
so
much.
I think, yeah, we can wrap up. Thanks, Dr. Swati, for being such a nice teacher, as always. Thanks, Harsha, for being a wonderful moderator.
Thank you
Experiences
so
that I
much.
have. Life is always an ongoing process of learning.
Yes.
So I have learned quite many points from the gathering that we had over there. I'm really, really thankful to you and the entire fraternity for having me over here, having invited me over here. Thanks a lot.
Yes, absolutely.
Thank you
So
so much,
much.
Thank you,
Thank
Dr.
you, Dr.
Atiko.
Thank
Thank
you,
you, Evelyn.
Evelyn, for
And thank
making
you,
this start.
everybody.
Please continue the Northeast chapter's flag. And thank you, Mohan sir. Thank you, Reshmi ma'am, for joining us. Thank you to all the state leads. See you next month.
Thank you.